Good afternoon. Welcome. We'll go ahead and get started with Ms. Ann McLeod.
Thank you. I think they're just going to load a quick PowerPoint. But good afternoon. Ann McLeod, California Hospital Association. Thank you, Mr. Chair and members of the committee for having us here today. We wanted to share some of our thoughts with you on the cost drivers that hospitals are facing. And I brought pictures. I figured pictures are worth 1,000 words, and it's a lot easier than listening to me read testimony. So the first thing that I wanted to share with you is start out by examining the U.S. compared to other countries. And we see that countries with higher spending in social programs see generally lower costs in healthcare. The U.S. really is an anomaly in front-side social spending, which results in higher back-end spending for healthcare services. One could argue that the U.S. healthcare spending would be less if more social investments were made. We actually applaud Medi-Cal and Department of Healthcare Services for looking at some of the social spending to be incorporated into the 1115 waiver, such as shelter and housing. I think it's important as we talk about the composition of how the healthcare dollar is spent. This chart shows a 3-decade comparison. The bar on the left is 3 decades ago. The bar on the right is essentially today's dollars. And over the last 3 decades, the hospital share, or that bottom blue section of the healthcare dollar, has actually decreased. It used to consume 42 cents of every dollar. It now consumes 32 cents of every dollar. And if I had to create a bar for the future, my guess is it would be even less going forward. This can be attributed to improved clinical practices, new drugs, which we've certainly been talking about, that manage chronic conditions, and certainly the focus on managed care. They've all contributed to this shift. We anticipate this shift will likely continue as medical advancements continue to be made and enhanced focus on wellness and care coordination. Let's dial down and take a look at how the hospital spends their money, what the costs of a hospital are. And the vast majority of hospital spending is devoted to its workforce, followed by costs for medical supplies and services, as well as life safety and diagnostic equipment. And then we can't forget technology, such as electronic health records. Those are mandated that hospitals implement those, as well as extremely onerous mandates due to seismic building requirements. And as we look at labor being a high proportion of the hospital costs, I think it's really important to take a close look at this chart. This comes from the federal government, and they have identified the highest 11 wage index areas in the United States. The highest is Santa Cruz, and they go on down the line: Santa Clara, Alameda, Contra Costa, Sonoma, Marin, San Francisco, Monterey, Solano, Napa, Shasta, Sacramento. Number 11, New York City. So we've heard about the high cost of hospitals and the spending on the labor workforce, and now we see that it's driven by these high cost demands, specifically in the Northern California market. Let's take another look at hospitals compared to private industry, and then specifically California hospitals compared to the rest of the nation. When we examine the growth of labor costs over the last 10 years on an index basis, private industry wage index has increased by about 27% over the last decade. U.S. hospitals, their index for wages has increased about 38% over the last decade, and in comparison, California hospitals' wage index has increased by a whopping 54%, in large part due to shortages stemming from arbitrary and unprecedented staffing mandates in hospitals. I think it's really important to talk about aging, especially in California. There were some that didn't give a lot of credence to the aging of the population in California. We think it's actually very important. California's population is increasingly older, and a trend that is expected to continue. There is no doubt that older populations will require more care, and further, they will shift to Medicare coverage, and we'll talk about that in just a minute. Over the decade from 2010 through 2020, it is projected that all of the population growth will be driven by over 55 population in California. And twice that amount, twice that growth rate will be attributed to the population over 65 in California. Why is that important? Because with an aging population comes an increase in the incidence of chronic disease. There is a positive correlation to age. And the higher incidence of elderly populations will contribute to increased demand for healthcare services. In fact, it's determined that for every 1% change in the incidence of chronic disease comes a corresponding demand in utilization of 6%. And several studies have shared this fact that 75% of all healthcare spending can be related to a chronic disease. So chronic disease and aging is an important factor in California as we look forward as well. And then specifically when we look at hospitals, we've heard a lot of conversation today about how the unit cost is getting higher. We don't disagree, actually. As hospitals see fewer patients because we're consuming less of that healthcare dollar, the patients that hospitals do see will continue to be more complex and require higher acuity care, which is measured here, the case mix index. It measures the acuity of patients, and it's grown significantly over the last decade. Higher acuity and higher complex patients will equate to higher per case costs. The case mix index is expected to continue to increase and potentially at a much higher rate than what we've seen over the last decade. We've also talked a lot today about California's great success with implementing the ACA. And hospitals are very proud of the role that they've played in doing that. And it's been a very high priority for them. Most policymakers and observers of the healthcare industry, though, fail to recognize that the implementation of the ACA is costing California hospitals more than $22 billion for the first 10 years since its enactment. And this is through cuts to the Medicare program. It's anticipated that by 2019, it's estimated that the annual losses California hospitals will experience in treating Medicare patients will top $9 billion a year. And it's important to keep those Medicare losses in mind as we look back at that aging population. And moreover, as we take a look too at the Medicaid population and the Medicaid reimbursement rates. The chronic and severe underfunding of government programs creates a cost shift to the commercial market. There's no getting around that. Government funding will continue to worsen as we see with the ACA cuts, and the cost shift will grow. I think what's most alarming on this slide is the very bottom dashed line. It represents Medi-Cal reimbursement to hospitals. Medi-Cal is anticipated to cover up to 1 in 3 Californians when the ACA is fully implemented. That means 1 in 3 Californians will pay hospitals a rate that is up to 40% negative margin for that hospital to provide care. So 1/3 of the patients in California will be paid at that lower rate if there are no changes. Despite that, though, I think we have a lot to be proud of in California. And despite the significant mandates, the cost pressures, and the massive underfunding of government programs, California actually delivers care on a per capita basis that is 8% below the national average. Why? Primarily due to our expertise in care delivery and care management. This has resulted in some of the lowest hospital utilization rates in the nation. Let me quickly draw your attention to a few of these. When you look at admissions per 1,000 population, ER visits, which really blows everybody's mind, inpatient days and outpatient days per 1,000 population, you can see California's ranking as among the best in terms of limiting or not overusing healthcare services on a per capita basis. Care management, care coordination, integrated delivery systems have all contributed to this result and quite frankly serves as an example for other states. California hospitals agree that aligned, integrated, coordinated care is absolutely necessary to improve costs and quality. We're not up here today saying that we don't want to control costs further. We support the movement away from providing care to more of managing health. And hospitals are leaders and partners. We heard somebody acknowledge the Vivity system or virtual network that was created. Hospitals were leaders in the development of that. And we're seeing this around the state. We're seeing hospitals as leaders or partners experiment both with public and private models to move in this direction. And again, we applaud the Department of Healthcare Services and the waiver to do a lot of demonstration in this area too. So to summarize, because I want to keep you on time, the drivers of hospital costs. This is what increased hospitals' costs. And while it's not an exhaustive or complete list, here's a summary. Inadequate levels of social resources and community supports are pushing more onto the hospitals. Labor shortages, high cost of California workers, and staffing mandates are increasing hospital costs. The aging population is increasing chronic disease and increasing the complexity of patients. Government program underfunding will continue to cost shift and will lead to a lack of access to primary care services. We'll see more emergency department use, increased hospitalization, and conditions that could have been hedged up front. And also, we can't forget the investments that are mandated in technology and in building requirement mandates. So we've come today not just with our problems, but with some solutions that we're happy to work with you. We believe there need to be appropriate levels of social support to reduce the actual healthcare costs. We can look at eliminating some of those arbitrary staffing ratios and ease the labor supply to lower costs. We should definitely increase care management and population health principles wherever we can. And we absolutely need to ensure access to primary care and reduce unnecessary ER use and hospitalization. We must adequately fund government programs to reduce the shift to the commercial market and the private payers. And we have to take a look at reforming the costly building requirements and seismic compliance. Thank you.
Thank you very much. We're going to move on to Dr. Stefan Lockhart, Vice President, Chief Medical Officer for Sutter Health. Welcome. Good afternoon. Thank you very much. Just push the button. There you go. You're good.
Okay, thank you very much, Chairman Hernandez and members of the committee, for the opportunity to participate in today's hearing. I'm going to, over the next few minutes, less than 10, look forward to sharing my perspective with you on what Sutter Health is doing to help transform healthcare, improving access, enhancing quality, and making sure that we make our healthcare more affordable. My remarks will be informed not only by my role as Chief Medical Officer for Sutter Health, but also by my 25 years of experience practicing medicine as a Sutter Health physician and what it means to be a part of Sutter, which, as you know, is a not-for-profit healthcare delivery system with a community of providers like myself who not only care for patients, but also we care about them. The foundation of today's Sutter Health took shape right here. It's homegrown, as you know, more than a century ago, coming together to provide for the needs of emerging communities, but in recent decades, rising costs, consolidation of health plans, and declining payment for services have made it increasingly difficult for doctors and hospitals to do it alone. So to help preserve community-based healthcare services during these challenging times, our physician groups and hospitals have come together to build our not-for-profit network. Sutter is now one of the nation's leading not-for-profit healthcare systems, comprised of 48,000 employees, 9,000 physicians, 24 hospitals, and a full continuum of care from outpatient surgery to home health care and hospice services. Our employees, doctors, and hospitals work together to integrate and coordinate care As you heard earlier, very important to have coordinated care across the continuum to meet the needs of more than 3.3 million Californians that we are privileged to serve. So we have worked very hard to make sure that our not-for-profit community-based health care remains viable, and our mission is about investing in improving the health care of all the people we serve over the 100 communities in which we serve, both those with insurance and those without. In every community in which we are present, we are there because we have been asked to come in and help, either by keeping a hospital afloat and helping to establish it on more solid ground, or being a provider that maintains access to care. We've stepped up time and time again, and as just a few examples, we serve as the sole community provider in rural communities like Amador, Lake, and Del Norte. We serve as a safety net provider for inner city communities like Oakland with Alta Bates Summit Medical Center, and in the Mission District of San Francisco at St. Luke's. We've assumed the county's health obligations in Santa Rosa and Vallejo. We've even donated a facility in San Leandro and helped provide financial support for its continued operation when we no longer operated it as an acute care facility. Built a hospital in Santa Cruz to address the community's concern about choice and access to care and reproductive services. And we're the sole provider of inpatient mental health services for youth and adolescents in the greater Sacramento Sierra 5-county region. In addition, we provide hundreds of millions of dollars a year to care for patients who can't afford to pay and to support vital communities programs. In 2013, we provided nearly $1 billion in that regard. But as you know, this commitment that we have made does not come without a cost. And as you've heard, labor is first and foremost the largest driver in costs for healthcare for Sutter Health, making up 40% of our expenses. And to deliver our partnership promise to our patients to deliver the highest quality care, we must attract and retain highly engaged and highly qualified employees who are committed to collaborating, contributing their creativity, and acting with compassion every day. We are proud of our commitment to competitive wages and outstanding benefits, and would note that this includes a fully funded pension for all 48,000 of our employees. You've heard about the issue of government reimbursement, and of course, our commitment for caring for a large number of Medi-Cal and Medicare patient beneficiaries is also a major driver of our costs. Sutter Health serves more Medi-Cal patients than any other health system in our Northern California footprint. Nearly 1 in 5 Medi-Cal patients receives care, 22% actually to be exact, receives care in a Sutter hospital last year alone. And in 2013, Sutter Health invested $520 million of our not-for-profit resources in the care of these patients covered by the state's Medi-Cal programs, because California ranks last in reimbursement, and the compensation we received does not cover the cost of the care that we provide. Similarly, Sutter also provided care to thousands of Medicare patients that required us to invest an additional $296 million in 2013, because the federal government also fails to reimburse for the full cost of care for the patients who are covered by Medicare. And with the implementation of the Affordable Care Act and budget cuts passed by Congress, you heard an earlier figure. I will tell you that the figure for Sutter Health, we face an additional $2 billion in reductions from Medicare program over the current decade. Regarding other cost drivers, we have seismic state mandates, and these mandates for seismic safety and investing in technology to improve quality also result in an increased cost. We have invested over $10 billion since 2000 to build and improve healthcare facilities in Sacramento, San Francisco, Santa Rosa, Davis, Modesto, Burlingame, and Redwood City, just to name a few. We've also invested $1 billion to meet federal requirements and patient demands and expectations to improve our quality of care through the implementation of an electronic health record. By the end of this year, our 24 facilities and affiliated medical groups will all be electronically up on the electronic health record and connected to seamlessly provide and exchange health information, which will be a great benefit to our patients. So at Sutter, we understand that the cost of health care and the rising costs is everyone's concern. That's why several years ago we adopted a strategic plan we call the Total Care Accountability Strategic Plan, with 4 major areas of focus. One is coordinating care across the continuum. The second is align payment systems. Third, eliminate preventable harm and improve affordability. So over the last few years, we've worked to streamline our business and support services to achieve cost savings, already reducing costs by as much as $3 million annually in terms of the total cost structure of our organization per year. We've also worked to reduce variation and improve quality. Variation reduction amongst our providers not only improves quality, but also reduces the overall cost of care, and our efforts have demonstrated results. Our variation reduction efforts have involved over 700 of our physicians, have touched nearly 106,000 patients, and resulted in cost savings of $30 million in the last 24 months. We strongly believe the clinical variation results in better outcomes and improved quality for our patients and helps to accelerate our pathway towards affordability. A recent Dartmouth Atlas study recognized Sutter Health as one of the most efficient integrated providers in the country, an efficiency and quality plane equal to such leading healthcare systems as Intermountain Health and the Mayo Clinic. Our Sutter Medical Network of aligned and affiliate physicians have been working together to provide access to high-quality care in our communities. Our network established quality, costs, and outcome metrics to achieve the ACA triple aim principles of reducing costs, improving quality, and enhancing health. And again, we are leading the state with our results recognized most recently by Consumer Reports and consistently recognized by the California Association of Physician Groups for our outcomes. Consumer Reports most recently published its ranking of the 170 medical groups in California, and our affiliates ranked in the top 20, with Sutter Gould Medical Foundation and the Sutter Medical Foundation ranking number 1 and 3 respectively in this state. CAPG has also consistently recognized our medical groups with their award of excellence, not only for quality, but also for cost containment. We've also heard a lot about care across the continuum and integration of care, and we believe that integrated, coordinated care is the best way to improve quality and reduce costs. Our efforts have been nationally recognized, and we have achieved quality and cost outcomes that are a model for the rest of the country, and have resulted in outstanding patient and physician satisfaction. I would like to draw your attention to our AIM program, or Advanced Illness Management Program, which was supported in part by a government grant from CMMI of $13 million to fully expand our integrated service throughout our geographic footprint. Our AIM program provides access to care 24 hours a day, 7 days a week for the sickest and most vulnerable of our patients, allowing them to manage their care at home and avoid costly, often unnecessary hospitalizations. AIM has resulted in reductions in inpatient and emergency hospital utilizations, reduction in ICU days, and reductions in length of stay and overall cost savings. For AIM to work, however, Sutter Health has had to invest in care managers, telehealth support, and palliative care providers for which there is no reimbursement currently from payers. AIM provides care to 7,500 enrollees, and it will be up to 10,000 by the end of this year. It has not only improved the care experience for our patients, but has had a significant impact on lowering costs, in particular, reducing hospitalizations by 57%, reducing the number of ICU bed days by 66%, and eliminating avoidable emergency department visits by 22%. This intervention targeted at improving the quality of care has also done a lot to reduce the healthcare costs, over $75 million of reductions based on current projections. This program's success is based on our ability to integrate and coordinate care across the spectrum of services. Finally, I'd like to draw your attention to our work with payers. As part of our total cost of care strategy, we're partnering with our payers to achieve our affordability objectives. We have partnered with Anthem Blue Cross to form a shared risk arrangement with the goals of improving quality for patients and improving affordability of care. Sutter is responsible for managing the care of over 100,000 attributed Anthem lives, including over 20% of complex patients with 2 or more chronic diseases. Sutter is utilizing its provider network to manage the day-to-day care of these patients and collaborating with Anthem to engage and educate patients on the benefit of enhanced care coordination. And we've already initiated similar shared savings plans with United, and we have plans for engaging in other risk arrangements in the future. With respect to technology, which you've heard about as well, Sutter has been using technology for the benefits of its patients, both with respect to the electronic health record, but also we have done innovative programs such as the eICU, or electronic ICU. We were the first health system in the Western United States to bring an online eICU for constant monitoring of critically ill patients. In our eICU system, intensivists and specially trained nurses use early warning software and advanced video and remote monitoring to monitor patients 24 hours, 7 days a week, and it's of particular support and value for areas in which this intensive care is not routinely available. The results have improved quality and a reduction in ICU mortality as well. And with our My Health Online, we have over 1.1 million of our patients who are connected electronically to their physician via our patient portal called My Health Online. Our patients have the ability to review their health record, order prescriptions, and conduct electronic visits and video visits with their physicians, increasing access and similarly reducing costs. Through these and other efforts, we at Sutter Health have held annual commercial health plan contract rate increases to the low single digits over the past several years. We accomplished this while raising the bar on quality and increasing patient and physician satisfaction and increasing patient access. So we know we've made progress in lowering costs, but we also know that there's a lot more work to be done. We won't be satisfied until, so we're also considered a leader not only in the highest quality health care, but also delivering a high quality care at an affordable cost, an affordable price. So I thank you for the opportunity to speak with you today, and I look forward to our work together to make healthcare more affordable.